Medurstand. Understanding Medicine.
Professor Aziz-ur-Rehman from Medurstand, and today we are going to discuss another type of tachyarrhythmia, another type of supraventricular tachycardia called atrial flutter. Now, you all remember that we have covered supraventricular tachycardias, paroxysmal supraventricular tachycardias. They are usually at the rate of 250, around that speed, and ventricular rate is usually regular. And today we are going to discuss what is called atrial flutter. Now, what is atrial flutter? Flutter is a condition, as the name says. The atria actually, they do not beat normally fully. They like flutter, like they beat so frequently, I mean so many times per minute, that there is no time for them to contract fully and relax. The speed is usually around 300, maybe 300 or more. But unlike atrial fibrillation, which is going to be our next topic, there is identifiable atrial contraction in the form of P wave. So since our conduction system cannot conduct 300 beats per minute, at best it can conduct 200 beats per minute. So there would be some degree of block, right? So an SVT, usually all supraventricular depolarization, they manage to enter the ventricles, but in atrial flutter, all will not be able to enter. So the atrial rate would be different than the ventricular rate. So I'm going to discuss atrial flutter today. This is our topic. This one, atrial flutter, okay? And this is going to be a relatively short video, I hope so, because it is a relatively less common condition and there is no big variety. I think maybe in 10-15 minutes I will be able to cover the topic. Now this is the ECG, and it is not 12 lead ECG, it is just one strip because we just need to study rhythm. What do you see in this strip? Suppose this patient has history of palpitation. So what do you see here? If you scan from left to right, what do you see? 1, 2, 3, 4. What do you think these waves are? These are P waves, right? Because you can clearly tell them these are P waves. There must be some T wave also merged somewhere, but it is not visible. There may be some deformity of these waves. For example, this good one, this little downward deflection may be T wave. This may be T wave, but all these waves are P waves. Okay, so if you analyze this strip, we have atrial rate, which is 300 beats per minute. Atrial rate would be calculated from these P waves. Now, if you see the distance between two adjacent P wave, it is just 5 small square. So 1500 divided by 5 would be 300 beats per minute. So it is 300 beats per minute, right? But it is regular. Please note down, this is 1, 2, 3, 4, then again 1, 2, 3, 4, 1, 2, 3, 4. You extrapolate, all P waves are coming at regular interval, but there is no way to detect these P waves clinically because they do not produce any pulse. You can only detect them on ECG. So atrial rate is 300 beats per minute. What is the ventricular rate? In this case, I calculated it is approximately 70. Why so? Because almost fourth beat is conducted. So first one, this is atrial, this is P wave not followed by QRS complex. This one is also not followed by QRS complex. This one is also not followed by QRS complex. Only this one is followed by QRS complex. That means only fourth atrial depolarization is allowed to enter the AV node and then continue on to ventricles. Why so? Because AV node has long refractory period and the rate is too fast. AV node cannot allow all these depolarization to enter ventricles. If that happens, the ventricle will also start fluttering. That would actually cause cardiac standstill. So this is, in other words, nature's protection. Okay. So in this case, in this patient, every fourth beat is conducted, all other are blocked. See, fourth, this is relatively regular. If you see the ventricular rate, these QRS complexes are ventricular and the rate is 70 and is regular. I have written regular oblique irregular and have striked irregular because in this particular strip it is regular, right? You see R waves are coming at a regular interval. So 70 beats per minute is very decent, very normal. If you examine this patient's pulse, you would pass it as absolutely normal, and you can never tell that this patient has got atrial flutter. So you can only determine atrial flutter on ECG. Now, of course, we do not do ECG on every patient. The patient would have symptoms of palpitation, history of syncope, or patient already has a known case of flutter. So that is why we do ECG. So this diagnosis is only possible on ECG. QRSs are narrow. Narrow means as narrow as normal, because every fourth beat is allowed to enter the ventricle, but it passes through the AV node and then passes through the conduction system just like normal depolarization waves. So QRS complexes are regular, narrow. Okay. So this is atrial flutter 4:1 block. Please, if you have any confusion, just send me a comment and I'll be able to explain it better. So this cycle could be 3:1, could be 2:1, could be 4:1, could be 5 or 6:1, depending upon the condition of AV node and the tone of sympathetic and parasympathetic nervous system, and could vary. In some patient it could vary, and I'll show you some examples. It could vary in the same EG strip, or it could vary at time to time. At one time it was 3:1 and at other time it was 2:1. But it cannot be 1:1, right? Because in no circumstances AV node can allow 300 beats per minute to pass into the ventricles. It has to be at least 2:1. So these are the criteria. Identifiable P wave. Why I stress on identifiable? Because in atrial fibrillation, another condition, you don't see the P wave. Although in some cases the rhythm could vary between flutter and fibrillation. In the same strip, at some part you think that this is flutter, and other parts you may think this is fibrillation. But in flutter, you have identifiable P wave approximately at the rate of 300 beats per minute, and it causes a sawtooth appearance. You see the sawtooth appearance because the wave is constantly going up or down and up and down, and that there is hardly any baseline. So that is why we call it sawtooth appearance. And RR interval is regular. In this case, it is regular. Of course, if you have variable block, then it would be irregular. But in this case, it is regular. And RR is any integral number of X. What is X? X is PP interval. So PP interval, whatever PP interval, because every fourth or fifth beat is allowed. So you would have any number. For example, in this it would be 4. So RR interval is 4 times PP interval. Narrow QRS complexes, unless patient has additional or pre-existing bundle branch block, conduction aberration, or anomalous pathway. This I have already explained earlier. So this number can be any number, 2, 3, 4, 5, depending upon what level of block is in the AV node. So these are the diagnostic criteria. I hope I have made the concept of atrial flutter clear. What about this ECG? This is 12 lead ECG, 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. I don't see any infarction. I don't see any bundle branch block. And of course, it is not sinus rhythm. And if we scan this ECG from left to right, you see the same sawtooth appearance. You see these P waves which are approximately 300 per minute, but you have RR interval which is variable. So as compared to the previous ECG, there are some differences. Atrial rate again 300 beats per minute, but ventricular rate is much less and variable. Less because it is like here it is like 6 to 1. 1, 2, 3, 4, 5, 6. Yes, here it is 6 to 1. Here it is 5 to 1. Here it is 4 to 1. Again 5 to 1. 3 to 1. So there is variable block. Okay, and that is why ventricular rate is irregular. Okay, so in this case, if you have atrial flutter with variable block, it would cause irregular. It would not be irregularly irregular. There will be some pattern, some discipline, some rhythm in this irregularity also, not very irregular like we expect in atrial fibrillation. So rhythm is regular and QRS is again narrow. But I think the difference between this ECG and the previous one is this variable block. Okay, so diagnosis is atrial flutter with variable block. This block variable is because of the varying sympathetic parasympathetic tone, the effect of drugs, and the condition of AV node. Okay, so it could get worse, it could become less severe. So that is, I think, the reason of this variability. But as I told you, AV node cannot allow 300 beats to pass. There has to be some degree of block. So this was, I think, another example, atrial flutter with variable block. This is now simple example, just repeat ECG 4 into 1. Atrial flutter 4 into 1. I don't see any problem. This patient may have ischemic heart disease. This patient may have cardiomyopathy. This patient may be under the effect of certain drugs, some potential cardiotoxic drugs like cancer medication. But I don't see any problem in the ECG. All I see is atrial flutter with fixed 4 to 1 block in this case. Another ECG, what do you think? I think it would be slightly difficult. You know, here you may pass it like normal. You see, this is, you might not pick up the problem. I will magnify it and I'm sure then you will pick it up. Okay, let do some effort. There is right bundle branch block. That is not what we are discussing here. Right bundle branch block is a coincidental finding in this patient. But that makes one point clear. I told you the in flutter QRS complexes are narrow, but if there is another condition already existing in this person which causes broad complexes, of course then the complexes would be broad, but that is because of the right bundle branch block in this case. So what do you see here? I'm going to show you this in greater detail by magnifying. Be focused on this one. What do you see? If you still haven't figured out, I'm going to show you one more thing. Look at this one. What are these arrows? These are P waves. This is P wave followed by QRS complexes. Another P wave followed by, no, not followed by QRS complex. This one is followed by QRS complex. Then this one is not. So alternatingly, one atrial beat is allowed to pass, the other one is not allowed to pass. In this case, the atrial rate is also not 300, it is like I think 250. You can make the calculation. It is like, I think my guess is that it is about 250 to 60 beats per minute. And it is 2 to 1 block. These arrows, they correspond to P waves, and you see alternate P wave is conducted. So this is atrial flutter 2 into 1 block. In this step, there is no variability. And the QRS complexes are broad because of a coexisting condition, right bundle branch block. So that was all. As I promised, this was a short video, just 15 minutes. So I covered atrial flutter. This is not a very common arrhythmia, but this could degenerate into atrial fibrillation, and atrial flutter and atrial fibrillation both predisposed to thromboembolic phenomenon So if you can identify and treat, you can serve your patient better. So I think that is why this video was included. Professor Aziz-ur-Rehman from Medurstand. I hope to see you again in my next video. Looking forward to see you very soon. And the next video will cover another important condition, atrial fibrillation. Thank you.